welcome all. Amuseum Thought for Artscience is a new age concept foundation established in Trivandrum, the capital city of Kerala. Amuseum intends to create knowledge pool based on convergence of art and science, creativity, which often deemed as never meeting barriers. In this decorative space, research meets creativity, and together they build an ever-growing cultural archives of art science practices. Sharing Thoughts is a series of talks, discussions, and presentations on art and art science. In this 17th edition, Amuseum discusses how to prepare for the upcoming pandemic. This webinar is jointly organized by Amuseum, Artscience, and Kerala Social Security Mission, Government of Kerala. I welcome Dr. Sajush, the trustee, founder trustee of Amuseum Artscience and a science promoter, to moderate and to invite panelists to this webinar. Thank you.
Yes, very good evening to all the panelists and all the participants. Preparedness against the pandemics. We tend to believe that the pandemics were only part of the history, but recent epidemics like SARS, MERS, EBOLA, NIPA, and the current COVID-19 scenario teach us that we are at the threat of pandemic at any time. The preparedness to combat the future pandemic will be on the major determinants of the survival of human species. We have an eminent panelist, Dr. Shamika Ravi, Dr. K R Thankappan, Rajeev Sadanandan, and Dr. Shibu Vijayan. They will share their thoughts on the preparedness against pandemic through this webinar. Before I invite the first speaker, I will just quickly go through our pattern of this webinar. We have a panel discussion. Each panelist have 10 minutes for the initial presentation. We have Shamika Ravi, Dr. Shamika Ravi. Madam will be speaking on health infrastructure in India and how it responds to the current pandemic. And the next speaker is Dr. K R Thankappan. Doctor will be speaking on management of pandemic by Kerala. And Sri Rajeev Sadanandan speaking on preparing for the new normal health system in the post-pandemic era. And last, Dr. Shibu Vijayan will speak on how digital technologies can redefine future of pandemic response. And after that, by around 7:48, we will have a 15 minutes audience interaction. Audience can participate in this discussion by raising the hand. They will allow them from the host. We will allow them by the audio, through audio or video, and you can send your queries through our chat box also. And the concluding rounds, the second round and the concluding round, the panelists will get 3 minutes, and the final conclusion by Sri Rajeev Sadanandan, and out of thanks by Muhammad Ashil, our Executive Director, Kerala Social Security Mission. And with this introduction, shall I invite Dr. Shamika Ravi. Dr. Shamika Ravi is a non-resident senior fellow of Governance Studies program at the Brookings Institution, Washington, D.C. She was the former director of research at the Brookings India and led the development economics vertical, where the focus is on financial inclusion, health, gender inequality, and urbanization. Ravi is a visiting professor of economics at the Indian School of Business, where she teaches courses in game theory and microfinance. She was also a member of Economics Advisory Council to the Prime Minister of India. She is also affiliated with the Financial Access Initiative of New York University. Ravi publishes extensively in peer-reviewed journals and writes regular opinion pieces in major newspapers. Her research work has been featured in and cited by BBC, The Guardian, the Financial Times, and most national and regional newspaper and magazines in India. Madam does not need any further introduction, and I am straight away going to Madam for the first speech.
Thank you. Thank you very much. Namaskar. It's very good to be connected with all of you. And one thing we have to realize is that despite all the distances and the disruption to our normal lives, technology does give us the opportunity and means to be connected, and particularly across this very vast country. And while we are joined in this pandemic together, it is very, very good to be connected with you and discuss this very important topic. You know, preparedness for a pandemic, I really hope that we continue to discuss this even post this pandemic. Because when we think of smart cities, when we think of designing a modern state, resilience is a very important concept. And resilience means that there should be a plan and the capacity to handle these kind of exogenous shocks. And pandemics have always been one which have been considered a major possibility, and yet I think no country today can claim to be well prepared for what it is underway. Now, in the Indian context, let me start out by putting out a few broad features of what India's health care system and our infrastructure looks like within the context of the current COVID pandemic. One thing to realize is that in the last 30 years, we have made tremendous economic gains. And with economic growth, we have seen that key indicators that we have been monitoring, whether it is specific diseases and disease burdens, but most likely health outcomes such as maternal mortality, infant mortality, life expectancy, they have all shown tremendous improvements with economic growth. So that's number one. What we have also seen is that state response, starting with, and of course, when I say state, I mean not just central government, but by and large, a lot of state governments and district administrations, which have been at the forefront of improving state capacity as far as public health is concerned. A big, I think, improvement in India has been coverage of publicly financed health insurance schemes. It's important, however, to realize that health insurance is just a financial instrument. It's as good or inadequate or bad as the healthcare that it can possibly buy. So to have a good health insurance scheme requires us to have a good healthcare delivery infrastructure and mechanism, which makes this kind of an financial instruments worthwhile. So that's very important to know that while the coverage has increased, the fundamental healthcare that it can buy has remained a big challenge throughout. And again, I'd like to reiterate that the the Ayushman Bharat scheme, which is a national scheme and one which has sort of a mission more to it, with the highest political office of the land lending its weight behind it. But there are two aspects of it. One is the health insurance component, but the second is the wellness centers, which is basically the primary health centers or the eventual delivery of what we consider primary health care in India. And yet in the common parlance, the most common discussions we have, almost all discussions on Ayushman Bharat is fundamentally limited to the health insurance coverage. And I think there lies the big crack, which needs to be addressed. The second aspect is that with improvement in insurance coverages, what we are seeing is there is some improvement in eventual out-of-pocket burden on people. But the impoverishment or the overall emphasis around out-of-pocket remains pretty acute. If we compare ourselves to other emerging markets, then Indians still continue to have a very high out-of-pocket healthcare expenditure burden, and that is a cause of concern. In the current pandemic, that again becomes an additional factor, because if people are infected and they happen to have the comorbidities or the complications with claiming insurance coverage. And of course, remember that even Ayushman Bharat is for the bottom 40%. There is a very large part of the population which does not have insurance coverage, so that becomes a concern. The second is this pandemic is fundamentally urban because of the nature in which it has been transmitted. And while it is going towards rural areas, a very large part of the burden remains in urban India. And yet, if you consider healthcare infrastructure, then we don't really have benchmarks for providing healthcare through the public system for urban India. So while we do know that these are the population benchmarks for rural India, when we say that how many sub-centers should be there, or primary health centers or community health centers. We don't have similar benchmarks for urban India. And that again is a big lacuna that needs to be addressed as soon as possible. Within this pandemic, another important feature to remember, and this is where the economics of it comes in, that infectious diseases are very different from other kinds of ailments. And a pandemic of this nature is infectious, which means that the externalities around infection is very high. So private healthcare sector is likely to have very limited solutions for large infectious diseases like COVID. So the emphasis and the reliance of public health infrastructure will always remain paramount. The minute we talk about widespread infectious diseases like this, which is also the reason, remember, that TB, and this is the broader context within which we should appreciate the COVID fight, is that while we have lost close to 1 lakh people to COVID, and that is an alarming number and we're all greatly concerned, but what we have lost over 6 months to COVID, we tend to lose 4 times as many in a year to TB. Now, TB is a big infectious disease concern, which India has been living with. So infectious diseases, while COVID has obviously brought this to the fore, but it remains a very large concern. And I think it is in that context that the finance minister spoke about enhancing infectious disease ward in every district hospital of the country. But it's a necessity right now and something that should be done on a war footing. Then, of course, we talk about all India scenarios, but we are a very big country where states are the size of countries themselves. And there are enormous variations in terms of the disease burden and the comorbidities that exist across the country. So even when we think of designing public health infrastructure, the biggest killers in UP, for instance, of women tends to be diarrheal diseases or diarrheal ailments. But obviously, when we speak about a state like Kerala, then it tends to be the cardiovascular ailments. So the way and the preparedness of the public health infrastructure has to respond to the existing context that they operate in, which means we have to highly contextualize, and we can't have sort of one model fits all, even when we talk of a widespread pandemic like this. Another aspect to appreciate is this big variation between public and private care in terms of the dependence of the wider population to these different sectors. In states like Kerala, Tamil Nadu, Himachal Pradesh, Chhattisgarh, Goa, there is a great reliance on public health infrastructure for most healthcare services. And yet, in some of our big populous states like UP, Bihar, Madhya Pradesh, Rajasthan, the reliance is overwhelmingly on the private health infrastructure. Now, this is where we have to acknowledge and accept the reality that 75% of India's health needs are met by private health infrastructure today. Because this is the NSS data, which tells us that more than 75% OPD is purely private. Close to 55% IPD, which is hospitalization, is exclusively private. Now, these things tell you that we can't shy away from the reality of where health infrastructure in India is, which means private caregivers are a reality. They are, and they have to become partners when we think of infectious diseases. And therefore, regulating this space in a way and in ways in which state can partner with this sector becomes very important. And time again, we are seeing across different states that frictions are arising. And those frictions, whether it is in the area of testing, whether it is in the area of care itself, those frictions really don't serve us well. In fact, they really pull us behind. And that does a great disservice at a time like this. Now, one key concern is people generally think that public care is for poor people and private care is for the affluent. The data has very clearly told us that, you know, in India, wherever public healthcare works, people across wealth categories prefer public health infrastructure. And this again, we are seeing from the NFHS data, that in states where district hospitals are run well, people across wealth quintiles approach the district hospitals. Whereas in places where it does not work, nobody goes to public health, including the very poorest, which means that the governance of public health infrastructure becomes very, very important. We cannot shy away from the fact that public healthcare infrastructure must remain the bulwark or the cornerstone of the broader healthcare infrastructure in the country, particularly against a pandemic like this. Now, the Lancet had come up with the vulnerability index for different states of the country to COVID. And in that, they had, of course, looked at the healthcare infrastructure. They looked at the comorbidities, the dependencies, so the age population, etc. And states like MP, Bihar, Telangana were very high on that vulnerability index. Now, 6 months into the pandemic, we know that if you compare the mortality numbers today, or even in terms of the case load, then that correlation is not very clear. In fact, there is no correlation between the vulnerability that we anticipated and the eventual caseload and the mortality. Of course, the nature of the testing, the way we are measuring, there could be many other sort of things to go into. But at the onset, what it is telling us that local government's response to this pandemic has been very varied and not always along expected lines. Some of our most affluent states, economically well-off states, have also had the highest test positivity rate. And there is no reason why that should be acceptable to the population. We have it's problematic that rich states are not keeping up with the testing adequacy ratio. So we need to test more. Another aspect, and this is my concluding remark, is beyond the healthcare. Healthcare is at the heart of what the economy is all about. Till we get out of this pandemic, and economic recovery remains elusive. And we have come up with the vulnerability index for the workforce as a whole. And it's important to inform this audience, which comprises of many people from Kerala, that Kerala, Delhi, Punjab, Haryana, these are states which come out looking most vulnerable because these states have very high urban population. These states have very high number of casual workforce and particularly in sectors which have been hit very hard by this pandemic. So we have to look at vulnerability to this pandemic beyond just the obvious healthcare outcomes, but also at the livelihood aspect of it. So I'll stop with that. Thank you for the opportunity.
Thank you, madam. We will move on to the next speaker, Dr. Professor K R Thankappan. Dr. Thankappan is currently working as a professor in the Department of Public Health and Community Medicine, Central University of Kerala. He was the professor and head of Achyuta Menon Center of Sri Chitra Medical Center before joining Central University. He is a public health physician trained in Medical College Trivandrum and Harvard University. He has more than 250 publications, including in the Nature and Lancet. Over to you, sir.
So I think I am going to present probably a very good scene from Kerala, because what I'm presenting is the Kerala's management of COVID in the first 100 days, which is probably the best time for Kerala compared to the present time. Next slide. So as I think Shamika has already mentioned, Kerala has a lot of problems, particularly with regards to the risk factors and comorbidities. Can I see the slide, please? It's not coming. Yeah, so I think this short presentation, I have a brief introduction about the Kerala health scenario, and then I go to the first phase of COVID-19 in Kerala, then second phase of COVID-19 in Kerala, and then the flattening of the epidemiological curve in the second phase of the COVID pandemic, and the major factors of success in the first 100 days in Kerala, and then the way forward and some conclusions. So I think, can I have the next slide? I think the Kerala state, in comparison to the other Indian states and some of the other countries, have very good health indicators. For example, Kerala is very close to, you can see from the indicators of neonatal mortality, under 5 mortality, life expectancy, etc. Kerala is very close to the European region. as it's very clear from the indicators. However, if you look at the health expenditure, the current health expenditure in US dollars, Kerala spent only 104 US dollars per capita compared to the United States 9,870. Although Kerala spent the highest within India, this is about 1% of what the United States is spending. That is why people called Kerala's model as good health at low cost model. So, but how? But Kerala has a lot of other problems. Go to the next slide, please. Particularly if you look at the morbidity, we have a lot of risk factors in Kerala, particularly when you are seeing COVID pandemic. The elderly population, we have the highest 12.6% versus 8.6% in India as per the latest census. Type 2 diabetes, 19.2% versus 7.7% in India. Hypertension, 30% versus 25% in India. Acute myocardial infarction or heart attack, 3.5% in 2016 compared to the national average is not known. Highest prevalence of asthma in South India, that's also a risk factor for COVID, you know. One of the highest incidence of cancers, barring the cancer incidence in the Northeastern registry, Kerala has one of the highest incidence of cancer. In spite of a very good health system in Kerala, you look at the control rates. Hypertension control rate is 12.3%, very low. Diabetes control rate is only 15.3%. This is comparable to, if you compare to best in the world, for example, Canada's hypertension control is about 65%. So we are lagging behind in that control. These are all risk factors for COVID. And also the high density, you have the third highest density of population within India. Next slide, please. So that is when we have the first phase of COVID. The first case of COVID-19 was reported in Kerala on January 30. And the second and third cases were reported on February 2nd and February 3rd of 2020. And all the three cases were Kerala students studying in Wuhan city of China who returned home. In January's second half itself, Kerala developed guidelines for testing, isolating, contact tracing, and managing COVID-19 cases, which helped to avoid spread from these initial cases. That was from the previous experience. I will come to that point. The second phase of COVID-19 in Kerala started when a family returned to Pathanamthitta from Italy. And there were a few cases, I think 8 cases. Very 6 cases were confirmed on March 9, 2020. And then the cases gradually increased to peak at 262 in the first week of April. The number of cases came down to 16 on May 8, which was the 100th day of COVID-19 in Kerala. So by that date, the epidemiological curve almost flattened in the state. So that is a big success story. So if you look at the confirmed, recovered, active COVID-19 cases and the deaths in Kerala from January 30 to May 8, 2020, you can see the the yellow line, you can see that is the flattening of the epidemiological curve. So that was a big success story. And in fact, Kerala was praised, I think, internationally also for this high success story of flattening the epidemiological curve within 100 days of the epidemic or the pandemic. So if you compare the Kerala data with, with regard to number of cases per million, case fatality and recovery rates in selected countries as on May 8, you can see the case fatality rate in the USA at that time was 5.52. UK was 14.81, and Spain, all these countries had a very high fatality rate. Even in India at that time, but it is 3.35. Kerala had only 0.6. The case fatality, that was very good at the time. Even the recovery rates, if you look at the recovery rates, Kerala had one of the highest recovery rates in 100 days, 96.2. But as you know, the recovery rates are actually falling now. Go to the next slide, please. So, and also I think the success was because one of the major success story was because of the people quarantined on April 4 and May 8 in the districts of Kerala. Lots of people were quarantined. And as you can see, most people were, there is a comparison, number of people quarantined April 4 and May 8. a large reduction even in the number of people quarantined because of the epidemiological flattening of the epidemiological curve. Next slide, please. So I come to the major factors of this success. Now, experience gained from NIPA virus epidemic. You may remember that Sri Rajeev Sadanandan, additional Chief Secretary of Health and Family Welfare, Government of Kerala, was the key person actually in managing Nipah virus at that time in Kerala, along with the Health Minister and the health team, both in the health services, private sector. Everybody contributed, fantastic management of Nipah virus epidemic in the state. And that was a big experience gained by the system that also helped. And adherence to the WHO guidelines, testing, contact tracing, and quarantine. We followed the guidelines as soon as the guidelines were prepared by the WHO. That was a very good reason, one of the major factors of success. Enhancing health infrastructure on a war footing. So in fact, the government of Kerala, I think, posted a lot of doctors and other health staff on a war footing to manage the health system. And enforcement of Kerala Epidemic Disease Control Act in order to, to implement this Epidemic Control Act, it was necessary to implement this act, and this helped the police people to find people without mask, etc. And the community kitchens actually helped one of the vulnerable population, the migrant population, about the 400,000 migrant population were at that time in the community kitchens. And they served these people with the food and required other necessary dietary items. That also was one of the major factors. And the stimulus package of rupees 20,000 crores by the government. And that was also a very, very helpful package because there was no job for the poor people. And this package also helped to give money, cash transfer to the poorest of the poor, and also the Anganwadi workers, Kudumbasri workers, all were supported by this stimulus package. I think the Break the Chain campaign probably was very effective in the first 100 days. That was one of the key factors of the success. That was implemented very effectively. And the expansion of the internet bandwidth and connectivity helped the people to work from home, particularly the people working in the IT sector. That was also a very good factor. And the political commitment. And in fact, the Chief Minister and the Health Minister, both the departments and other departments were actually behind the pandemic, and they were actually managing it very, very effectively. And we, as you know, Kerala has a very strong decentralized government, and most of this implementation was done through the decentralized government, or the panchayat Raj governments, local panchayat, municipalities, and corporations. And the media support was extremely high in that first 100 days, although it has come down. I will come back later on to the media support. Media support also helped to communicate very effectively this to the common people, and that was a major support for containing the COVID pandemic in 100 days. Next one. So I think at that time, the word forward was after relaxation of lockdown and increasing return of migrants from other countries and other states, the number of cases is going to increase. That has exactly happened now. And elderly and those with other diseases need to be protected by reverse quarantine, which is a huge challenge. But fortunately, I think we have been successful in that. That is why the mortality is very, very low. More health professionals may be affected. That has exactly happened. A lot of health professionals are affected. And anticipate for another floods in Kerala and prepare for manage both. It has happened, but the flood was not severe as in the previous flood, but we had some floods this time also, and we were able to manage it very, very nicely. Yeah, so concluding, I think Kerala anticipated COVID-19 when China reported the first case was, Kerala was prepared for that, and also ready with all the systems to manage the epidemic of COVID-19 in the state. First COVID-19 was reported in Kerala, which was the management. This was the first time in India a case was reported. Within 100 days, Kerala almost flattened the epidemiological curve. And major factors for success were experience of the state in managing Nipah virus epidemic, testing and isolation of the confirmed cases, intense contact tracing and quarantine with community support, political commitment and leadership of the state, media support, and decentralized governments. And of course, Kerala need to be prepared for more cases after return of migrants and the floods. This is exactly happened. I think I think the next presentation by Sri Rajeev definitely will go through the current situation of Kerala. Thank you very much for your attention.
Thank you, Dr. Thankappan. And we will move on to the next speaker. Sri Rajeev Sadanandan is the CEO of Health System Transformation Platform, a not-for-profit company that works on health system research. In the past, he had worked as Health Secretary to State of Kerala, the CEO of RSBY, India's National Social Health Program, and Program Officer at UNAIDS. He was an editor, WHO Report on Cancer 2020, and commissioners on the Lancet Global Health Commission on Financing Primary Health Care. Currently, he is also an honorary advisor to the Chief Minister of Kerala for management of the COVID pandemic. And Rajeev Sadanandan will be speaking on preparing for the new normal health system in the post-pandemic era. Over to you, sir.
Thank you. Let me thank the organizers not only for inviting me to speak here, but also to speak on a topic on which I don't have to refer to the present reality at all. You know, I can speak from a theoretical frame. And Dr. Thankappan, I'm not going to talk about the present situation in Kerala. We'll leave that for you in the panel discussion. May I have the slides, please? See, David Cutter, I think a month ago in a paper in JAMA, had commented that that we have to be that starting from 2002. Next slide, please. Starting from 2002, world has faced a real or a potential pandemic every year. 2002, you had SARS, H1N1, 2009, H1N1, 12, and so on. So, but even the health systems that were that kind of, and those of you who worked in this remember that there was a similar, alert that was posted for SARS and for H1N1. We survived that. But this time we were caught off guard by the speed of COVID-19. It's got the biological implications. I won't go into that. Now, since we're going to be faced with pandemics, and a lot of these pandemics actually come from, I'll come to that later. Next slide, please. Now, the problem is going to be that when you want to reconfigure the health system, it's important that every aspect, all the aspects that are listed here and even more need to be reconfigured. And as Shamika mentioned, the extremely tenuous nature of the health system in India being what it is, can we do it is a question which thankfully I don't have to address in this presentation. When you look at surveillance, in the past, we talked of one health, but now the surveillance has to become one world. In the past, I used to joke that if anybody caught anywhere in the world, we have to reach for a handkerchief. We did that for HIV and so on. And that's one thing that Kerala realizes, that given our connectivity to the rest of the world, you have to be conscious of what happens in outbreaks beyond our borders. But this pandemic has shown that anywhere in the world, that vulnerability remains there. Ebola was a huge epidemic, but never got out of the African countries. As SARS was more communicated, but it still got maintained. Thankfully, if you study the spread of SARS and H1 and SARS-CoV-2, we have the epidemiological models for transnational spread. Most of the people who modeled it actually use a SARS model. Wuhan to different cities, and from there to different areas, the disease would spread. So we know now that how the disease is going to spread. The models are available, they've been fine-tuned, and these are something that have to become part of our surveillance for the future. And we also know that there is a much greater need for international cooperation on IHR. Unlike some of the world leaders are saying, it's not the time for isolation, it's the time for working together. Now, we have been talking about One Health, including, because most of these diseases are going to be zoonotic. The microbes that are commensal in many of these these organisms, when they get into the human being, they become dangerous. The rate at which we are destroying forests in Malaysia and all over the world, it is only going to get worse. So we're talking about health and monitoring veterinary, dairy and meat and so on. In future, we have to start monitoring wildlife also. This pandemic has shown that there is no need to go for manual tracking. I believe, and Shibu is going to be talking about this later. We know now that artificial technology, including artificial intelligence, was very successfully used by countries like Taiwan and Korea, and it's important to be learning from that. The future cannot be fought with the kind of instruments that we have. Next one, please. Next slide. So when you look at the service delivery, all aspects of we're familiar with the term surge capacity, but my supposition is that surge capacity will need to not only at hospitals but across the sector, rewriting our understanding of emergency preparedness. Resilience for other systems are something that we know. But resilience in other systems to manage health is something that we never thought of. All aspects of service delivery have been challenged: infrastructure, human resource, drugs and consumables, and so on. So when policymakers look at this, they will need to look at each of these and then see how we need to reconfigure our policies. Hospital planners have to do, and not only hospital planners, urban planners, architects will start thinking about what is the impact of their work for a future pandemic. Next slide. In the case of infrastructure, the facilities were overwhelmed by the sudden spike that happened, and the Fanggang hospitals, the Nightingale Hospital, Fanggang Hospital in Wuhan, Nightingale Hospital in UK, they all become a big model for us to follow. In future, this cannot be a knee-jerk reaction. This is something that we have to plan for. We will have to have your current versions of greenfield hospitals, current repurposing of hospitals. So either you can have the system of dedicated hospitals, which no country in the world can manage, or you can have multi-purpose buildings built from right now, indoor stadia, exhibition centers, to be built in such a way that it can be repurposed when we need it. Now, new designs of this is something that we have never looked at before. Our Indian building standards look at individual use. It may be necessary to rethink this and start looking at alternate uses of buildings in the future. It's not a new thing. After the Second World War, when the nuclear disaster was imminent, if you go to many buildings in the Europe, you will find nuclear bunkers. We need to start thinking about a similar thing for a pandemic of the future. Next. The other thing that has got badly, next slide, please. The other thing that has got badly affected is the HR. In health, about 60 to 80% of our investment is in health, and in the past we looked at, like, China was able to divert people from other places to Wuhan. If the entire country is affected, like what happened in Italy and so on, you can't do that. And we will see pandemics in which entire country and even the entire world will get affected. So we have to start thinking about HR in a different way. Like you repurpose buildings, even HR will have to be repurposed. Cadres will have to do tasks that they are not legally allowed to do. Nurses, pharmacists doing work that they are not regulated to do, and even laymen will have to be recruited, and we have to tweak the regulations to be dealing with it. We know that any new pandemic, any new epidemic will have only supportive care, and training modules can be done for it. IT-enabled training systems can be built up, because supportive care is something that is going to be generic, and only disease-specific skills, which again will emerge, will have to be added. And health authorities can start preparing this generic training module, and it can get, rather than developing it as and when it comes, you can have it prepared, ready for it for the future. Now, when you look at any clinician who does not know how to manage a treatment case, it feels handicapped. This case, when it happened, we had no idea. One great thing that happened was many of you would have read the initial papers that came from Wuhan, the first 32 cases and the next 98 cases. All of us, and the papers that came from Italy, all the clinicians across the world learn from, from these. And credit to all the international journals, the papers were expedited, bypassing review. It had some bad this thing, and everybody got a free access. Clinicians have been learning on the fly, and what we need for the future is an international clearinghouse for clinical practices, so that clinicians can share knowledge and learn from each other. We need a system like that, not an ad hoc system, but something that can be made a permanent structure of the international health architecture. RCTs still remain the gold standard, and we actually look foolish by bypassing some of those RCTs. But since RCTs take randomized clinical trials take a lot of time, we need a more rapid system for validating treatment modalities. Otherwise, we'll continue using things like the plasma treatment and so on. The other major problem is going to be financing treatment in countries that do not have universal health coverage. And we saw the impact of that in the US and in many other countries, including ours, such as PPEs, ventilators, and we know how the supply chain got so badly choked. When you're in the market, you couldn't buy ventilators because the affluent countries are building it up. And China, which is the source of many of these, was using it for their geopolitical purposes. Now, it is, and in India, we've seen rampant profiteering. Now, we will need to look at the reliability of the supply chains. The good states in India have looked at government supply chains, but we may have to look at the sector-wide supply chains for the future. If a reliable drug or a vaccine were to appear, then their production, procurement, and supply chains will be needed. Now is the time to build it up. And for the future also, we need to look at international pooled procurement mechanisms to ensure that poor countries are able to access drugs and vaccine during an emergency will need to be built up. Next slide, please. This is not something new. This is something that has happened in the past with TB, HIV, and so on. But it's important to have this ready. Now, mental health. The pre-COVID, I identified one of the first papers identified some 3,500 plus journals that looked at the mental health impact of the previous quarantine one. We still don't know how bad the impact is going to be on the elderly, on the health workers, on children as it happens. Now, how do you counter that? Information is the key. What we learned in SARS 2002 and managing NIPA in Kerala was people need to understand the situation, and that makes it a lot easier for them to accommodate. And trustworthy sources are the best source of rapid communication. Generally, it is government, but when government is not trusted, then we have a serious problem. Some of the other problem is going to be, we've seen that quarantine, if it is voluntary, does not cause as much of distress as when it is imposed. So the messaging should focus on altruistic nature of self-isolation. And I've seen a lot of cases where people have not been compelled but have gone into it. We must also remember that the impact of closing down schools, keeping children in flats and so on. Frankly, I'm really worried about the long-term impact of this on the future generation. Next one, please. The next slide, please. The other problem is going to be what we saw in many countries is that social purposes cannot be managed by health sector alone. Other sectors have to come in. We saw that in India. Financing, regulation, all these have to come together. Even within the health sector, again, what we saw in some of the places where health system was placed under threat, the lack of coordination within the health sector between different levels in public sector, within the private and public sector also. We need to have a system, a real-time system that can manage this. And technology enabled coordination is something that is possible that we need to work on for the future. Health system resilience, and this is a topic that we've been talking about since the Ebola days. It refers to a whole range of issues in dealing with shocks. I'm only talking about protecting essential services and provision of services right now, like child vaccination or pharmacological management of diabetes, TB. This is necessary to maintain health of people in the long term. COVID will go off, if not now, a little later. But the long-term impact caused by lack of child vaccination, interrupted TB treatment is going to be even more long-lasting. In future, we have to develop systems that can firewall these essential services and maintaining them. Increasingly, we're finding that evidence came from Wuhan, then from Italy. Health services will be difficult in affected countries, and while elective procedures can be postponed, what we are seeing is that the postponed ones have now become urgent, and it's going to become a major cause of even death. In Wuhan, the number of deaths from these conditions are supposed to be very, very close to the number of people who were lost to COVID. The treatment that should have been done and was not done. Next. The other major thing that will happen when a pandemic strikes you is an infodemic. Infodemic always follows an epidemic, and this was not a major issue in the past. But again, what we saw with NIPA is unless the social media houses are able to put their house in order, and there is no sign of that happening, the best way is to combat them on the same ground. When a false information is put out, you get there and combat it by a trusted source. In fact, during NIPA, every day we're monitoring feeds on different social media, and the moment you get it, hit back, and that is the only way that is possible. Now, again, what was proved by Ebola was that when the most important element of combating an epidemic is trust in government. When people trust a government, official sources will be the best mode of providing information. If you don't trust government, then we are in serious trouble, because when people don't trust the government data, then they're looking for an alternate source of information. Unfortunately, the alternate source might be WhatsApp and that kind of social media stuff. But it will be good for alternate, medical, scientific, or academic sources to be built up. Even if you trust, even if you believe that government data, assuming that government will let you carry that data, but it's important to have that infodemic part also. As I mentioned before, the social media, mainstream media, all of them have been should be scanned. And Dr. Thankappan talked about the support of the media. In Kerala, right from the HIV epidemic in the 90s, I found that the mainstream media have always been very supportive. In NIPA, we had one journalist who got out of hand, and I spoke to the editors that went down from that editor, and everybody was so strong that mainstream media was one of the biggest sources for support to the NIPA. Till now, the mainstream media has supported the COVID area also, and I find there's a high level of concern in media about our response of how this is going to happen. And when false and mischievous messaging is detected, it is important to crack down. You have to take measures. You have to take regulatory measures. I will not spend much time on it, because the next pandemic, we don't know where it is going to come, and we all benefited, by China sharing the genome sequencing by the first week of January, and that is because China has been investing. Wuhan had an excellent lab, and that was and the fact that they had been sequencing coronavirus in the past also. Unfortunately, in India, we do not. It's getting built up, but I hope it's getting done. Because viral infections affect poor countries, enough investment is not done on the treatment for viral infections. And the developed world always thought that they had to focus only on cancer and cardiovascular diseases, and the world has paid the price. And the health systems, we've seen that even where everything was in place, the systems not functioning well has created problems. Health systems research, here I confess to a conflict of interest, that's the area that I'm working in. This also needs great attention because we need to understand how the health systems interact with each other and what are the pitfalls, how can they work together. Other health correlates, managing behavior change, something that we are just not able to understand. When people have access to information, why the hell can't they act responsibly? We need to understand how people behave and how people behave over long term, and also communications management during pandemics. We will know this pandemic caught us by surprise. But if we understand the basic framework of our health intelligence, service delivery, financing, coordination and research systems, and understand how they need to be repurposed to deal with a potential or a real pandemic that will help us later, we have to get that lessons, and policymakers, researchers have to be aware, have to understand what these are there. And believing that the past will handle a present epidemic is slightly foolish. So it might be necessary to go back to the drawing board and redesign the system. It doesn't matter that we have a legacy system. We may have to redesign systems in, just as I mentioned about the building, etc. So on. Preparedness is going to be expensive, and given the underinvestment that we have seen in health systems, I know this is asking for too much, but we have seen the economic impact of disruption of lives and economy that it has cost us. Compared to that, the additional cost of investing in these systems that are recommended will not be too much. And even if God is kind to us and there are no more pandemics, the health system will benefit by the preparedness. So all the future policymakers and clinicians who are listening to this, I hope that next time we have the pandemic, you will have a better preparedness than what we had with this. Thank you.
Thank you, Rajeev Sadanandan sir, for an excellent presentation. We will move on to the next speaker, Dr. Shibu Vijayan. He's medical doctor and public health expert with over 25 years experience of working across the complete spectrum of public health systems. Expertise in designing and deploying private sector engagement strategies for urban health system, bring in experience working with the MSF, WHO, National TB Program, the Union, the PATH, at the PATH, providing the technical and strategic leadership for TB, urban health system, COVID-19 response in India, and digital health. Key accomplishes are demonstrating private sector engagement interventions, patient provider support agency, that is PPSA, digital adherence technology rollout, and scientific publication focusing on or group member of public-private mix working group for TB hosted by Stop TB campaign partnership. And Dr. Shibu will be speaking on how the digital technologies can redefine future of pandemic response. Over to Shibu Vijayan.
Thank you, Dr. Sajishan, for the nice introduction. I also thank for the speakers who spoke earlier. That is a nice segue. So Rajeev sir presentation, nice segue to my presentation. He also touched upon the importance of technology and data and information in preparing for an epidemic. So what I'm bringing here is a few of just looking at how this digital architecture and the ecosystem looks like now, and how we could I've been using that in a better way, which is already around, and perhaps preparing for the next health system transformation from a digital perspective, and which will help us in a better response to a pandemic. That's something which I'm going to touch upon. So what you're seeing is a display of information, a dashboard which clearly segregates and classifies states based on the confirmed cases, deaths, and tests done per million, and also the daily average growth of COVID cases. why it has been possible, and thanks to Rijo AM, who is actually deeply doing this analysis and every day tweeting it for the public interest. And I should also acknowledge Shamika's analysis over here. I'm not discounting her analysis, Shamika here. Why this is possible, and also look at this is a Karnataka dashboard. And our organization internally done a dashboard analysis, and then we ranked it according to certain criteria of completeness of information, public utility, and how they are utilizing this. And we came across top three states. One is Karnataka, and second is Maharashtra, and third is Kerala. So I'm not displaying here Kerala's this thing dashboard. So the information over here, what I want to convey is why this is possible is just because of one standardized way we all agreed as a nation to report the number of cases in the ICMR diagnostic portal. Had it been we had different systems of reporting, we would have gone haywire, and nobody have a clue of what is happening in the country, and also at the state level, how do we design and deploy this. So that's the whole background of the discussion, and that's the power of information. Which is again starts from the data collection itself. If you are not having a system which is not, your data collection is not sanitized and clean up well, and you are looking at a situation where it's garbage in and garbage out, and somehow that is and now being that traffic is being regulated well by one portal and one system, our data gaps, I mean, in India of reported cases by the states and the national level is roughly around, still it is around 100,000. I mean, I'm still struggling to understand why it is like that, why there is a reporting gap. But in the normal public health system standards, I mean, I won't call it as a standards, but in the experience, I have seen at least 20 to 50% of the data variations. If here, roughly we are seeing only 10%, I would say that's a blessing. So as a background, I would say that digital is not a solution. So when I say digital, don't think okay, everything can be solved by a digital thing. It's an enabler. It's actually could potentially accelerate. It could potentially optimize. It could fasten our decision making. It would inform us in a better way to take decision in the right way. It has limitations, and we should be cognizant about it. And I'll come back to that. Community participation is a challenge, and I'll also look at the Aragya Sedu and then and say that why it has not been, the uptake is, not that optimal. And here, when it comes to the digital, and if you want to connect with the digital from the two, so if you bucket all these parties in the health system into three buckets as users or the clients as patients, and then the service delivery is health system, and we have a regulators or a policy maker or who is paying for it, that is predominantly the government or even the private sector. And you have the data bar, which cut across all these things. And everyone has a role in the digital ecosystem, so we cannot shy away. So that is where the problem with the Aragya Sedu also. We have invested in an app which is fairly good. We have had partnership with the private parties like MyMedTribe who actually have all these functionalities captured in this thing, which have a sense of your location, and it clearly says that X number of people are infected, but you have to do your task. You have to inform the system to make sense out of it. And in the current scenario, we have almost roughly around 15 crore users. Given that India has a penetration, reported penetration of around 35 crore plus smartphones, roughly half of it, less than half of it is now included. So the scale of digital is limited as of now from the perspective of Aragya Sedu. So this is one area which we need to be cognizant when we think about a digital transformation. Health system also need to move to a paperless. So one thing we have seen with this is, as we see in the banking system, there was a window period for changing from the behavior from the paperless to a complete digital transformation. It took a while, so that kind of window period or delay should be expected over here. Then the interoperability and integrated system. We have multiple vertical systems in this country. Across public and private, within the state itself, we have hundreds of apps. So that is a challenge when it comes to the interoperability and integrating. So without all these things, it is going to be a mess. So managing this itself is a project for many governments. So I am I'm looking at digitized health in a digital India from an aspiration perspective. Why we are actually now talking about it. So one thing COVID has helped us in accelerating many of this process. We have seen digital telemedicine rule getting cleared, and then now we have access to telemedicine. We have e-Sanjeevani on one hand. We have seen some sort of acceleration in national digital health mission has been set up. The bureau, the blueprint has been out. Now people are talking about that. The PM has emphasized on that. We have to yet get into the details of it, but again, the thinking is in line with how the digital India is moving forward. So, which is again articulating about powering about artificial intelligence and machine learning. Rajeev sir also mentioned about the disease prediction capabilities should be one part of the preparedness in the coming pandemic. Adopting digital solutions across the care pathway. I would like to bring in here the TB as an example. The only system which I have seen, the mature system to follow on your patient from when you look at as a presumptive cases to the end of the treatment cycle, when we declare it as cure or completed, and which have capabilities of incentivizing, throwing the incentives, so direct benefit transfer to the patient as well as the providers, and also informing whether the patient is sticking onto the treatment. So it's a complete architecture ecosystem, though have limitations about the bandwidth, the backend infrastructure, which is also improving. So if you don't have the system which covers from the full patient care cascade, it is ought to fail. And if you put that in, and that has to be comprehensive and put that in one system. You cannot build silos for one app for case finding and one app for case management, and then if you create systems for bridging that probably is what right. So blending digital approaches is into traditional healthcare is again addressing the access and affordability. A health system fits into the overall strategic direction. So it should also talk to the Ayushman Bharat, Swachh Bharat, Digital India, and the Make in India. And I see a potential space here as a space that health tech is a transformative phenomenon. So given that, I am just proposing what should be how should we take it further forward for the next pandemic, or like how do we the health system transform? The state should have a digital map, a roadmap for digital transformation. They should have investment plan for making the infrastructure. We should also consider about human-centric principles and also build in incentives for uptaking. And both the health system also to be prepared to change into the behavior adoption. As I said, it has to go for a paperless situation. And design adaptable situation in a continuous improvement and inclusion of advanced tools, including AI, robotics, and all stuff like that. So given that, I'm just putting forward to imaginary situation here. I am going to be the patient here. I did a Arogya Setu risk categorization here. I cuffed into Doctrinal Cuff app and being screened and by telemedicine, e-Sanjeevani, and I will categorize as a home care patient. So I'm being, sorry for that. My SpO2 is monitored and that information goes to the cloud. I am taking X-ray with the Cure AI solution. These are all Indian technologies I'm talking about. This is not a foreign technology. Screened, and then my prognosis is being assessed, and I am categorized. My drugs here you see actually informs whether I am taken drugs for every day or not. And I have been assessed. This is a real assessment done through a mobile app. I've been assessed for my lung health situation, and it cleared as no situation. So I'm happy. Behind my mask, you can see the health system as well as I'm happy. So this is just an imaginary scenario we try to construct within the existing technologies. And we have a lot more in the technology space to come in. 10 years back, almost 16 years back, Facebook built capabilities of reminding us for the birthdays. And after 15 years, we built, Indian Academy of Pediatrics built a tool which reminds your child for vaccination. That is the level of delay when we see in the digital spirit, moving from an analog to a digital. There is, I would also want to reiterate to the audience that there is nothing like a digital health. It's just health and being contemporary and also getting adapted to the digital systems. So I'm just stopping there. Thank you.
Thank you, Dr. Shibu, for an excellent presentation. And we can have some questions from the audience. Forum is open for questions.
Can I ask a question?
The participants.
Yeah.
Yeah, Ramakuti sir.
Yeah, I mean, this is in response to, I mean, it's very interesting. I mean, I unfortunately missed the part of the first presentation, which was very important because I came in a little late. I was traveling. But I was especially intrigued by Rajeev Sadanandan's presentation. He brought up many issues which are very relevant. But one question I would like to ask is, this what you're suggesting or what you're envisaging is a major reconfiguration of the health system. If that is so, would the political decision makers have the stomach for that? I mean, I don't know how else to express this, because they have other priorities like expanding hospital facilities, which are of course immediate. I mean, the pandemic may kind of go down, I hope, it will, something else will happen in the future, that is definite. But people are only concerned about immediate concerns, and they might be worried about, heart disease, diabetes, all those things. So they will be looking for more beds, more hospitals, and not like a health system which can totally respond to a pandemic. And this is a problem which all of us in public health face, because people are interested in their individual health, except when there is a pandemic like this. I mean, even when there is a pandemic like this, they're not really thinking in terms of public health. They are thinking in terms of their own health. I don't know how else to put it, but I would like to hear your thoughts.
Dr. Ramakuti, I had taken an anticipatory bail at the beginning itself by saying that what I'm saying is not linked to reality. It's more a wishful thinking than, I mean, it's a wishful thinking, but sorry. When you look at some of the states that were notorious for ignoring health system and the way they have responded, actually I'm surprised. Some of the so-called bad states, they responded with a great deal of alacrity. My hope is that at some stage, it'll translate into a great investment in health, what shall I say, willingness to invest in health. Now from there, before we blame politicians, are we ready to, are we ready with what should be done? Do we ever push surveillance ahead of, our clinical requirements? So that's why I've been saying, that the health planners, the health policy makers, the reconfiguration needed is not on the indoor stadia, but in their head first. Now, if that can happen, only then, and which is why it's important we do that exercise now, so that if and when, hopefully, a demand is made on us, we are ready with those suggestions. So let's hope for the best. We've always hoped that 1.2 to 2.5, we've been dreaming about it. So let's continue, let's hope that the good day will come. Thanks.
Yeah, this is Dr. Noble from Medical College Trivandrum.
Okay, Noble, please ask.
This is regarding again, Rajeev sir and Shibu all should be probably answering this question. I'm working for last 20 years in health service, that is 6 years in health service, and then moved to my medical education. I haven't perceived any change in the system. Actually, basically, how the patient present to the hospital and the management, and then till, as Shibu perceived, till the patient is cured. That system has not changed for last 20 years. In spite of lot of management mechanisms have developed in India, nothing has changed. And I'm wondering, my case sheet, which is started from the day one of medical college, is still there in the same paper form, same format. Nothing has changed. Why it is like this? Probably we should see this as an opportunity to change.
Yeah.
$1 million question. So Rajeev sir also mentioned about the behavioral economics and behavioral sciences. Some of that applications we also need to bring in here. I would say this is an opportunity for that matter, that this triggers this accelerated some of the decisions, this pandemic accelerated some of the decisions. And that could actually be a segue to a larger transformative change. And when we think about, we have signs and symptoms of that. When I mentioned about the telemedicine got cleared, the National Digital Health Mission, if we go to the chapters of it, and then when it gets implemented, I would say maybe in 5 years, not in 10 years, 5 years, we should see a comprehensive system in health management, which is digitally enabled, which is AI driven, which would be predicting that, okay, X medical college, which also predicts the pandemics based on the legacy information, which captures the vector information from the vector department, which captures the weather information, which predicts the climatic change. So all this comprehensive, we cannot have an isolated, health system transformation. We need to have a comprehensive transformation along with our we move along. I am optimistic in that sense, and hopefully I would think and pray for it from we move from an analog mode to a digital.
Noble, maybe you have heard about medical college in Trivandrum where e-health was introduced and initially picked up. You know why? Because the people who sit in OP are PGs and house surgeons, young kids who are so happy with doing this rather than writing. The moment it moved to the senior physicians, it won't work. So the change, where should the change start? I won't know. So even when you look at the primary health centers, the FHCs worked. In FHCs where we had youngsters and people who are willing to change, that worked. So the basic thing of changing is, are you ready for the change? Secondly, it doesn't happen overnight. I've looked at, before preparing the e-health for Kerala, I looked at NHS, I looked at the US systems. NHS, the GP practice, which much more homogeneous than ours, took 9 to 10 years before it stabilized. Now, if we are, as Shibu mentioned, the banking, I know the kind of trauma that was there when the banking shifted. This is much more complicated. So if we make up our mind, and I'm counting on the youngsters because these kids they wouldn't even know how to write, so I'm counting on them to adopt the technology as we go. But COVID has actually changed a lot of things. In fact, I'm aware of doctors in Mumbai who respond to migrant when his client, who is a migrant worker, has gone back to Bihar. He takes a consultation over WhatsApp and then takes some money on Google Pay, and only then gives a prescription. So people, it's not going to be the same for future. But important thing is the decision makers have to decide that a change is needed.
I'd like to make a comment here. I think we are still beating around, missing the woods for the trees occasionally when we talk of digital solutions or HR solutions and so on, or management information system fundamentally looking to change. I think until health becomes political in this country, you see, when you compare Kerala to the US, you forget that US elections are fought and lost on the back of public health or health. Right? I mean, when was the last time, do any of you know what is regarding health in any political party's manifesto? So I think we also have to understand that unless health becomes political, and that should be the demand, and hopefully this pandemic does prove to be a wake-up call against that kind of a transformation. I'm really hoping people demand, and that's the time when I think policymakers will respond in much more drastic way than piecemeal solutions and so on.
I think this time the elections in Kerala will be fought on COVID.
Shamika, I don't agree with you. Kerala, and I heard the presidential debate yesterday. We don't go to that level, but health is a do or die thing for the government in Kerala. In fact, when we had an epidemic in Kasaragod, our border district, the chief medical officer just laughed at it. You're talking about 5 deaths. What is wrong with you? But 5 deaths of malaria, indigenous malaria in Kerala can make the health minister lose a job. And again, we've seen in Andhra, YSR won this election, partly on the health agenda. So health has been had become a political issue many times in the past.
I am also not that pessimistic, I think, because I worked in the Kerala Health Services from 1980 to 1990, about 30 to 40 years back. And now, I am working in a tertiary care institution, academic institution. I go to several primary health centers and community health centers. I see a lot of change. For example, at least hospitality changes. There are good seats available in the primary health centers, just like tokens are given for the queues, etc. A lot of changes I could see in the health system in Kerala. and other places also. I think there are, but as maybe one may not be happy enough to go by this. The digitalization, digital technology was not taken up by the health system. That may not be enough, but I see a lot of changes in the system.
In fact, Kerala is not the best example of a supply side changing the health sector. It is Tamil Nadu. The conscious decision by government that changed, and it's something that never been properly recorded.
Definitely, the COVID scenario, especially the webinar boomings, will be a big boost for the electronic medical recording system, EMR systems, especially in the older generations, senior physicians. Any more questions?
I'm not sure whether this is a question or a concern, but yeah, anyway, I'll raise it. Most of the plausible solutions raised by the panelists, seem to indicate that we would need a global collaboration, to be prepared for the next pandemic. So I would like to, have an opinion from all the panelists on what are the possibilities given the current world order, and our analysts being, most of the places.
I think, Shamika, you would be the right person, given the current changes in the international thing, whether we are equipped to deal with an international response.
Well, it's unfortunate that so many forces are colliding at the same time, which means, you have the trade wars going on. There is an intense anti-globalization movement amongst large economies. And yet, this is the time when we have realized how interconnected we are, that a virus emerging from one province of China, and how quickly it can go and spread, throughout the world. And I think while it is unfortunate, I do think it is also an opportunity to reorient and bring about changes in the large global multilateral arrangements and the understanding that we have. So I think the role of WHO, the UN, these institutions will have to be strengthened despite what the current tensions seem to be, because the economic forces, I think about it even within the country. We are a large country. We cannot have the kind of containment strategies, for instance, that China had. Or we can't have containment strategies the kind New Zealand had, small, or Japan. These are small island nations, so they can do many things, which we can't. At the same time, we also struggle with government capacities, not just again at the center, but all the way down to district administration. Because eventually an individual citizen's experience in this pandemic is not going to be determined by what Prime Minister Modi says, but what my chief medical officer or my, the community health clinic, what is the capacity at that level? Or what is the testing capability available to me? So while we heard, and we have written a case as well on Kasaragod, and what a fantastic job that was done in the first 100 days. But we know that the nature of this interconnectedness is such that today Kerala has the highest rate of growth of active cases in the country. Some of it could be within the state, some of it must be from movement across states. And again, that is the kind of interconnectedness in large federal democracies that's a reality that we have to live with. I think one small point that I'd like to emphasize, because both Rajeev and Shibu and also Dr. Thankappan mentioned, that look, we have more data than we have ever had historically. But it's not going to be just digitization by itself. We need a lot more data scientists. We need to convert this data into knowledge. And again, it's not just knowledge of any type in a dynamic situation, which we are right now grappling with. Why have we not done more cluster analysis? Why have we not made more effort to analyze the contact tracing data to identify super spreaders? That is what cluster analysis is. In fact, the entire Japanese story around containing this virus has been just that. The SARS pandemic showed that only 6% of patients or infected people were responsible for 80% infections. So these are real-time analysis that has to happen and feed into policy making at the highest, and the lowest sort of localized level. So I think there is an entire, missing, and there's a gap within the Indian, public health and health capacity overall, not just within the government, but I think also outside of the government, which we need to address, including in progressive states like Kerala. We need to give research its due to handle this in the future. Thank you.
Yeah, I just want to comment on Shamika's opinion. We need to invest more on research, at least in teaching institutions. We have very difficulty to get things done in medical colleges because there is no system in place. Like if you have Sri Chitra, there is a system in place to conduct a research. I recently joined a part-time PhD program in Chitra. So there is a system. It is grossly inadequate or lacking in medical colleges. And moreover, there is a huge gap between the epidemiology researchers and the clinicians in the actual providers. There is no communication is happening between them. So clinicians see the patient individually, the public health see as a whole, and there is no link between them. That is what probably can generate more information which will be useful for the general public as well as policymakers to bring into guidelines into practice. I think Shibu should give some comment on that.
I will doubly agree with you, and I would also say that we also need to bring in the non-medical partnership into the medical. So the medical fraternity is much more siloed. We need to break it and bring in more data scientists and engineers into this thing. And so far, this epidemic also we are managing just with the medical systems. We have a lot more we could have done with when we bring in engineers for in having proper ventilation, airborne infection control. How you design your markets. So, Shamika, you touched upon the smart cities, which is developing. Probably these are all components need to be brought in. So Noble, I would say that I don't have a prescription answer right now, but I would say that we need to deconstruct our existing system of looking at, okay, I will talk to only my situation, my system, and I will take decision based on my patient I see. To larger, that's again a part of a larger behavior change, and also bringing everyone together to tackle this thing. And we have seen that now we are grappling because of the silos. We need to break the silos. That is probably it will take some time. And digital is going to be an accelerator for that silo breaking. That is my mantra and Indradhanush for that. Thank you.
We can quickly move on to the last round. I invite Dr. Shamika Ravi for the concluding remarks.
Well, I'll keep it very brief.
Yeah, thank you.
I think such valid points have been made by all the speakers. At the current situation, I think the infodemics, or the lack of credible, transparent, and timely communication, needs to be made a high priority. Because, and I'm speaking now with, wearing my hat as an economist, I am greatly concerned about the very, very slow economic recovery that we are seeing in India, despite the fact that our relative severity of the pandemic here is much lower than what you have seen in Western Europe. And even those economies have done a much faster pickup. And I think part of that tension is to do with people's fear. Some of it could be irrational, but a lot of it is because people just don't know. And I think the credibility of the information is in terms of easy, affordable access to testing, if required, hospital beds or any kind of institutional intervention if required. I think just that knowledge can go a long way into giving people confidence to get back to consuming, to working, and to investing, which is good for the overall well-being and livelihood of the economy.
Thank you, madam. Over to Dr. K R Thankappan.
Thank you. I will take on Kerala because I presented on Kerala. I think Kerala now there's a complacency issue because I think of the very low mortality rate. The case fatality rate is also very low now, even at 0.4%. Probably that has led to a complacent attitude among the population and the political leaders. In fact, the compliance of the social vaccine, for example, social distancing, mask, etc., has come down drastically. And in Kerala, and the Onam festival. In the Onam festival also lots of people came together, and all this crowding, overcrowding, I would say, has led to the large resurgence or the increase in the number of cases. And because Kerala was performing well, for example, the low mortality rate, for example, in Kerala, if you calculate the total number of deaths in Kerala per day, it will be about around 500 normal deaths. But the COVID deaths are only 10 or 20. So people are seeing that this is not a serious problem. So that is why that has maybe led to a major problem of less compliance to this social vaccine, social distancing, that has created, even among media also actually gradually changed, because their priority has gone to the political issues, because the COVID has come down to the law issue now. Because earlier, as I said, media supported very, very much for compliance and also the management of COVID-19 initially. But because of this problem, a success story of Kerala probably has led to this political issue, and the media also probably, they have to, of course, change with the political system and also the political leaders. That is what created in Kerala, as Shamika said, I think we have the largest number of cases per day now.
Thank you, Dr. Thankappan, and move on to Rajeev Sadanandan, sir.
I think I'll take off from where Dr. Thankappan left off. To some extent, we are responsible. You see, when many of us who work in the area of public health know that there is a certain course a viral epidemic will take. To assume that Kerala is something special and the virus would make a special exception for Kerala was, I'm sorry to say, stupid. And after I joined here, one of my major effort has been trying to persuade people, saying, look at what happened to Mumbai, look at what happened to Delhi. There is no way the virus is the same, and you can't have islands of good health in ocean of disease. You will go that way. But we always kept maintaining, no, Kerala is special. No, I hope that has gone off, and Dr. Thankappan, to some extent, all of us are responsible for giving. I mean, it's good when I look at other states. I'm very happy at the level of confidence and the level of high morale that is there for Kerala. But it's also important to realize that the virus was there before us, and virus will be there after us. And there are immutable laws of epidemic that, given our level of understanding of public health, we should have understood. I mean, it's still not bad. I still don't believe that, yes, sorry, but might see the capacity getting breached. But the work that was done was fabulous. But I still believe that our epidemiologists and public health people did not model this correctly and knew what should have been obvious to anybody who was watching the epidemic in rest of India. But I'm still confident that knowing what is happening in the state, I'm sure that the state will catch up to manage this condition.
Rajeev sir, any final word on the future pandemics?
No, future pandemics is, there's a very important reality check that Dr. Ramaguti pointed out. I was hoping that nobody would point out. In a country that is not done, what Shamika pointed out, that is not done even basic public health, primary care spreading across the country, is it realistic to look at something like this? The answer is no. But as people who work in this area, should we think about it and create alternate scenarios that we can present to policymakers? The answer is yes. Thank you.
Thank you, Rajeev sir. And last, we move on to Shibu. Shibu, please.
As we are discussing on Kerala, I would also have my bit on Kerala. So in the initial 100 days, the success story was essentially due to our committed, we could contain that kind of small numbers with our efficient systems. when we get out of proportion, what we need is actually digital tools. And what we lacked is that. So we moved from had it been we are emphasizing on our data systems, as Shamika clearly mentioned about cluster analysis and stuff like that, we would have moved, we would have better in an efficient way we have invested. We also had issues like acceptance of these things. When we talked about tracking of patients with telephone information, that's one of the key information to identify the clusters and stuff like that. So, and here I would want to bring in, if you want a digital transformation of your health system, you should start from your leaders, political leadership. Here comes they should get convinced about the usefulness of this thing. And we share the data left and front and all this center and all these things from the Facebook, and they capture your information. And we are in a transparent world. I think we getting anal about all these things from in a pandemic response is ridiculous, I would say, in the contemporary world when we see digital tools. But that preparation, that change in behavior should start from there, and then naturally things will fall in line. And if you don't have a leadership, both political consensus on that, we cannot transform this thing. I would say that all our efforts should be targets towards changing that thing, that behavior of our political leadership to think in a more contemporary digital mode than an analog mode. Thank you so much.
And thank you, Shibu. And we will move on to the last part of our session. And I invite Dr. Ashil, is the Executive Director of Kerala Social Security Mission. And he is the frontline warrior of COVID fight in Kerala. And he is almost a big star in our media space in Kerala. One last word, the entire Amuseum team is extremely thankful for the support of you, Ashil, in person, and the Social Security Mission Kerala. And a big thanks for all the panelists for an excellent webinar. And I am signing off. I invite Dr. Mohammad Ashil for the concluding remarks and vote of thanks.
I'll be very brief. I'll straight away go for a vote of thanks. As most of the discussion has already happened. So it was indeed an enlightening session, and good discussions happened over that. And let me be very straight to my duty assigned to me for expressing the gratitude. At the outset, I must express our sincere gratitude to our all-time hero of health department who have worked in recent time, Rajeev Sadanandan sir. I must confess, sir, one thing, like when you are around, actually I get a bit conscious and very conscious and a bit nervous also. It's actually, I try to overcome that, but it's an involuntary response which comes out of me because I often see that way. That's something very involuntary. So being a hardcore fan of Rajeev Sadanandan sir, I take it as an honor to express my gratitude for presenting, for being a panelist in this webinar.
Thank you.
On behalf of all organizers and participants. And Thankappan sir, is one of my favorite teachers, and I had an opportunity to be at the Menon Center during my MPS time. It's great hearing you again, sir. Thank you very much on behalf of all the panelists, all the attendees in this session. So next, Shamika madam, you have actually enlightened us on the various aspects of, especially the economic aspect of COVID-19, and many perspectives in that. Thank you very much, madam. Then next, Dr. Shibu Vijayan sir is one of the real public health professionals, which actually inspired us in at least me in taking public health as a profession. So thank you very much for your great session. Thank you, sir. And to the moderator, Sajesh Gopalan sir, who has actually been involved in almost all the sessions, all the music sessions. He is the person who actually been part of all these things. Thank you, sir. And to all the attendees, all the participants, and to the organizers, Amuseum, and everyone. And I express all the sincere gratitude to all the participants and the attendees. Please, thank you very much.
Good night.
Thank you.
Thank you.
Good night. Good night.
Thank you.